All right, we'll go ahead and get started here. My name is Sara Raiser, and I'm the founder of the National Grand Rounds Running Medicine program. This is our June edition, which I'm very excited to bring on board Dr. Dan Cushman. He's accompanied by Dr. Brian Atkinson, and then in spirit is Dr. Kyle Judkins. I'm going to do a little bit of housekeeping and make some announcements, and then I'm going to have them get started here. So, a couple of announcements. We've got a lot of things in flux with the Runners Clinic at UVA, so a few things coming down the line, but a couple of things that I want you to put on your save the date. We will be having the UVA Running Medicine Conference happening likely in the March timeframe of 2027. So dates should go out about that relatively soon, including our keynote speakers. So pencil it into your calendars. If you happen to be a local runner, parent, coach, otherwise supporter, we are going to have the UVA Runners Edge, which is a summit for high school runners. So a quick education day at the beginning of the cross country season happening on August 15th. More information to come, but make sure to throw that on your calendar for that Saturday morning if you happen to be in town. So, without further ado, I'm going to introduce our speakers tonight, and I've got some short bios here. We're going to be talking on identifying tendon injuries before they start, challenges, and opportunities. So, Dr. Dan Cushman is a professor in the University of Utah Department of Physical Medicine and Rehabilitation and is the director of non-operative sports medicine research. He is board certified in both sports medicine and physical medicine and rehabilitation and specializes in musculoskeletal ultrasound, nerve injuries, and endurance sport specific injuries. He serves as the team physician for the University of Utah track and field and cross country teams and is also the team physician for the University of Utah swimming and diving teams. His research interests include musculoskeletal ultrasound for the treatment and prevention of injury and low-cost treatment techniques. He also recently was a recipient of the AAP Early Career Academician Award, easy for me to say, and AAPM&R's Innovator and Influencers Award. So congratulations on both accounts in 1 year. Dr. Brian Atkinson is a primary care sports medicine physician and assistant program director of the Sports Medicine Fellowship at Mayheck in Asheville, North Carolina. Apparently, we crossed paths at the Olympic trials, marathon trials in 2020 before COVID, interestingly. As a lifelong runner, Dr. Atkinson is particularly passionate about working with runners and endurance athletes. He is team physician for UNC Asheville Athletics, Warren Wilson College Athletics, and medical director for multiple road and trail running races. He takes pride in educating his patients on the importance of physical activity, nutrition, and overall well-being as part of a comprehensive approach to health. Athletically, Brian has been a lifelong competitive runner. He ran collegiately at Duke University, where he earned second team All-American honors in the 10K and dabbled in marathoning post-collegiately, qualifying for the 2016 Olympic marathon trials. He now primarily enjoys trail running in the mountains of Western North Carolina. And last but not least, Dr. Kyle Judkins is a board certified sports medicine and family medicine physician. He serves as core clinical faculty for the Sports Medicine Fellowship at Mayheck in Asheville, North Carolina. Dr. Judkins specializes in the diagnosis and treatment of musculoskeletal injuries with a particular interest in tendon injuries and caring for endurance athletes. There's a trend here. He frequently uses musculoskeletal ultrasound both as a diagnostic tool for evaluating tendon, ligament, and muscle injuries and to guide precise injection procedures. Dr. Judkins is passionate about helping athletes and active individuals stay healthy, heal from injury, and perform at their best. He is team physician for Warren Wilson College and is co-medical director for Hellbender, a 100-mile trail running race, as well as the medical director for Cataloochee Ski Patrol, and recently was asked to serve as regional medical director for the High South Region Ski Patrols. Outside of medicine, he enjoys trail running, mountain biking, skiing, overlanding, and traveling with his wife and their adventure-loving Boston Terrier Beans. So without further ado, I'm going to pass this over to Dr. Cushman, and then Dr. Atkinson is going to speak. We've got a recorded segment after that, and then we'll jump to some Q&A. So as they are talking, please add your questions to the Q&A function, and I'll be moderating that section at the end.
All right. Well, thanks for having us. I really appreciate this. Kyle is in Italy right now. I am not. You can see behind me. This is definitely not Italy. I was thinking maybe I should put like one of those green screens up and put this back here and but no, I'm definitely not in a nice place right now. But thanks for having me. And I'm gonna share my screen here, kind of go over some of the stuff we've done, and would love to just kind of share what we have done here with runners, and would love to collaborate with other people who have similar interests and talk about all this. So, um, I'm here at the University of Utah. Sorry, there it goes. We did get some foundational funding for some of the research we've done here. And we're just mostly going to be talking about tendon injuries. So, as you know, some of these kind of ruptures are pretty common, especially in jumping sports. Um, but it happens in everyday people as well. But I think the reason we're talking today is because we see it all the time in runners. And then in particular, we really see it mostly in two tendons. So we see it in the patellar tendon, we see it in the Achilles tendon. Both are common in sports in general, but in runners, we see these fairly commonly. So it's even been up to 29% of runners in some studies will have Achilles tendonitis. Patellar tendinopathy can get really high, especially like I said, in those jumping sports. But you're going to see a lot in the runners as well. In the general population, still quite a bit considering how many people we got here. There's lots of things that contribute to these, though. So, in general, we kind of look at them from our medical minds, especially in sports medicine, as being, these are overuse injuries. It's a load issue. Or no, you're just not training right. You're doing that stuff wrong. It's about how you're running. It's a form issue. There's lots of different things that we look at and when we think about these, but it's important to remember that it's not just as simple as training. It can also be things that they did, medication. So fluoroquinolones can contribute to these. It can be systemic disease. There's lots of links between Achilles tendonitis and heart disease, for example. People's weight, all these things can kind of play a role. So it's important to remember it's not just training, it can be other things as well. So the whole point of this talk is we want to talk about why this happens and maybe we can do something about it before symptoms start. So I think of it this way as, you've got a tendon, you've got a healthy tendon versus a tendinopathic tendon. And the important thing here is these are structural changes. These are things that physically change within the tendon. It's not necessarily just an inflammation. It's not necessarily just something else like that that's causing it. These are actual structural changes. Structural changes are things you can see with imaging. So MRIs are common. Ultrasound, these are the things we use fairly often. For bad Achilles tendinopathy or patellar tendinopathy, you can see these with x-rays even. So these structural changes are things you can see with imaging. And in general, there's a logical progression that we see over time. They start with a normal tendon, they get this change, and then they develop pain. So no surprise there. But the reason I bring that up is because maybe we can do something when they get the structural change before they get pain. That's the whole idea. So the thought would be maybe we can intervene on tendinopathy before symptoms start. So if I expand it out a little bit, we start with a normal tendon, then it becomes this kind of black box of some kind of tendinopathies brewing, but they're not feeling anything. Then we get to the early tendinopathy stage. Oftentimes that's a tendonitis, and then we get into the phase where they've been having tendinopathy for a while. So the thought here is, what if we could prevent things by getting to this stage early? So could we get to them when they have this preclinical tendinopathy before it becomes its early tendinopathy? If we look at a normal tendon, we have been using ultrasound a lot. Ultrasound's cheap, it's available, you can move it around, it's portable, it doesn't have any radiation. There's lots of advantages to it. And as time has gone on, it's becoming the standard, I would say, for a lot of these tendon injuries and tendon evaluations. So we can see what a normal tendon looks like. We don't really know what preclinical tendinopathy looks like, but we sure know what tendinopathy looks like as well. So maybe there's this in-between phase where we can say, oh, that's what it looks like now. It doesn't look normal, but it doesn't look like it's the tendinopathy. Maybe there's something in there that we can do. Talking about ultrasound right here, I don't need to belabor the point. So when we're thinking about just doing imaging, things have really shifted. This ultrasound used to be really, really bad. These were what got published, and for people who publish papers, this is the best that you could find. So if these are the best images they could come up with, you can see how ultrasound was not necessarily the nicest thing to visualize tendons. there have been other things that have been used. This one is called ultrasound tissue characterization. I don't know if any of you in the call have seen this before, but it's basically a jig with an ultrasound probe attached to it. And the concept is that you can kind of repeatably evaluate a tendon. And their theory is that you can also evaluate the differences in collagen within the tendon. You can look at number one being normal collagen, level four over there being very disorganized collagen. The problem is when they've looked at this over time and done systematic reviews of these, they have not found that this UTC can really predict tendinopathy. It's been tried before, just hasn't been as good as we had hoped. So, what has worked? So, let's look at the data for these. So, is there a way that we can kind of go into that preclinical tendinopathy? And I'm going to just touch really quickly on, they've actually even done this for the UCL for baseball players, and they found that you can look at the UCL and you can see that there are changes that occur that might be more predictive of injuries. They've done it in more than one study. So for the first was an American, the second was a Japanese study. So it's been done, is the point. And these are relatively new. I think this one was last year. But more importantly, for what you guys want to know about is kind of athletic populations for stuff we care about. I don't think anybody on the call really wants to know about the UCL all that much. But for the patellar and Achilles tendons, this one, sorry, I got something right in the way. For the patellar tendon, you can see how there are many studies here. And what this graph is showing is that if you scan people who are asymptomatic, the N is the number of subjects who were scanned, and you look at people who got injured later, or you looked at people who didn't get injured later. And what you look for is to see if the ultrasound shows an abnormality in their tendon. So a bunch of asymptomatic people, you scan them. Is their tendon normal or abnormal? And if their tendon is normal, we are expecting them not to get injured. If their tendon is abnormal, we're expecting them to get injured. So how good is that? And what we find is that if you take all these studies together, different disciplines, different types of studies, different sports, we find that there is a risk ratio of 6, which means that if you scans an athlete's tendon and it is abnormal, they are 6 times more likely to get injured than somebody whose tendon is normal. That's for the patellar tendon. If we look at the Achilles tendon, similar, about 4 times more likely to get injured if their tendon looks abnormal on imaging, and that is for people who are asymptomatic. So, how can we kind of use this? Normally, within medicine, we consider screening tests, and a screening test is where you take people who have no symptoms, you try to identify who's at risk, and you do that using a test. And ultimately, that's what we're trying to do here is we're trying to take people who are asymptomatic, can we scan their tendons and see if they're going to get injured later on? Screening tests are only good if they have this little 2 by 2 table. So for those of you who are in med school, I'm sure you have nightmares of this, remembering this vaguely. But ultimately, it kind of matters because what you really want to know is do you have true negatives and true positives? So if they're abnormal, they develop pain. If they're normal, they don't develop pain. If every negative is true and every positive is true, you have a perfect screening test. That never happens in reality, but you really want to maximize though and minimize your false positives and false negatives. So if you scan a bunch of normal tendons and they still get injured, or you scan a bunch of abnormal tendons and they never develop injuries, what's the point? So that's what we're trying to identify is can we do that? So like I said, if I scan someone and they're normal, that should mean that they have a low likelihood of injury. If we scan them and they're abnormal, that means that they're more likely to have an injury. But what seems to show so far is that they still are not very likely to get injured, but it's much higher than if it was normal. So what I'm here to present is kind of what we have done so far, and I want this to use this as a segue to Brian and Kyle's study because they recently did this and kind of explain how we've done this. And so for people who are trying to do research in the future too, A, we're happy to collaborate, all of us, but B, I kind of want to go over our what has gone well, what has not gone well. And this doesn't need to be all about research, but I'm hopefully going to paint a picture of how this has kind of developed. So back in, I guess it was 2019, 2020, I can't remember the exact year, we did this study and we took 139, it was for the Salt Lake Marathon, half marathon, and full marathon runners. And we brought them to the expo and we scanned their Achilles and patellar tendons. And we did our study. And it showed that Achilles tendons were 3 times more likely to be injured, patellar tendons 2.5 more times more likely to be injured in the following year. That sounds great, right? The study was really bad. Like it was a bad study looking back on it, but that's how we learned. So there were a ton of limitations here. So the big thing for me is that we scanned these tendons and we never saw the patient again. Only half of them even responded to our survey at 6 months. There was the pain that they reported. Many people, if I said, "Do you have Achilles tendonitis?" they could say, "Yes, I do." But they might actually be talking about their ankle or they might be talking about their knee. They may not actually know what Achilles tendonitis is. So people reported back to us. And again, only half of them reported. When we tried to review the images, we did a terrible job of saving them and looking at them again. So the study worked kind of, but it wasn't very good. But then we got a grant. And grants are great because they give you money. And when we got money for this, I think we got $5,000 from AMSSM, American Medical Society for Sports Medicine. So they gave us a grant, and that really did help in a lot of ways. So suddenly we could pay participants, and we would say, "Hey, we're going to give you money, a gift card, so that if you do this, you actually respond back." Our follow-up was 80%. So believe it or not, just giving people gift cards, they're more likely to respond to that. So we looked at 138, about the same amount. We found pretty similar results actually. So this study was, in my opinion, was much better. Like we did a decent job, but it wasn't great. So when we looked at it, we were saving images of the tendons, so our reliability was pretty bad. If I said that, "Oh yeah, that's abnormal," and then I looked at it again 2 months later, I might have said it's normal. So it wasn't great. We again used self-reported pain. We didn't really measure vessels within the tendon, that kind of thing. So then we got a big grant. And so if you guys remember the good old days of the Pac-12, we collaborated with Washington State and Stanford. The Pac-12 paid us a ton of money. And what we did was just this. Sorry, my mouse is touchy. We did ultrasound scans on a ton of athletes. We looked to see who was abnormal or normal, and then we monitored them. But we're really good at monitoring the athletes. We have full medical record systems. We have athletic trainers. We can really monitor the athletes. And so we just wanted to see, were they injured or were they uninjured? And so we did this once a year for 3 years. Um, yeah, we apparently like polo shirts, and I realize I'm wearing one right now. So going forward, we did these three institutions. We had to do a very large study. Once you get to multiple institutions, things get a lot more challenging. So we needed research coordination. So Luke here really helped a ton with that. We needed statistical help. This is Masa. We needed amateur statistical help. That's me. And we had about 500 gigabytes of videos. So we looked at about 700 athletes and had to review 10,000 videos on all these athletes. It was a huge undertaking, but it resulted in tons and tons of data, which results in tons and tons of publications, which results in us sharing our knowledge with the world. And I found that when I have received a lot of calls just about this because people have read these papers. And so it actually made a huge difference. This was the biggest paper that we had, was kind of going over everything. And it talked about what we found out of this. So like I said, almost 700 athletes. And I'm going to just break this down real quick. We had more women than men, and we found quite a bit of patellar tendon ultrasound abnormalities. So, men were almost half of them had an abnormality in the patellar tendon, and women about a third. Very few Achilles tendon abnormalities. So only about 1 in 20, 1 in 15, somewhere in that range, had an Achilles abnormality, and the plantar fascia, which we see all the time, was even lower. So this is again is the collegiate population, but not that many abnormalities in the feet and ankle, but the patellar tendon, tons of them. So then what we did was we kind of added them all up. We took out people who had surgery. We took out people with other predisposing issues that would kind of cloud the study. So we took those out. And we ended up looking at almost 1,400 tendons and plantar fascia. We found out that a lot of them had had prior injuries, and then many of them were symptomatic when we scanned them. Not everybody was asymptomatic, so a lot of them were symptomatic. Then what we did was we followed them for a full year, and we did that once a year for every athlete for 3 years. It ended up being about 500 distinct athletes. and a few of them did them a couple years in a row. And if you do some pretty complicated statistics for it, ultimately what we found was that if you look at this bottom line right here, these are people that had a normal ultrasound. Less than 3 or 4% of them would get injured. If you looked at people over a year who had an abnormal ultrasound, you're seeing a ton more injuries. And this is just for the patellar tendon. And then when we kind of broke things down, who was more likely to get injured? We said, well, we can kind of break this down into a lot of things. Maybe they have pain at the time, so they're symptomatic or asymptomatic. Maybe they had a prior injury to the area, or maybe the ultrasound was the big deal. And what we found was actually the ultrasound was more predictive of them having an injury during the season than even having a prior injury or even having pain at the time of scanning, as crazy as that sounds. Because a lot of people had pain at the time of scanning but had a normal ultrasound. I don't have it on this, but it was pretty interesting how the ultrasound was actually more predictive than a lot of other things. When we say an injury, we said people who had something that was bad enough that they had to miss some practice or competition. So a lot of people might say, yeah, my tendon hurts, but it's not really that bad. I can still do everything. We didn't count those. We didn't want to count those. When we look at the Achilles tendon, same picture. So pretty much everything kind of matched in regards to ultrasound for the tendons. For the plantar fascia, pretty similar. We had less people who had it, so it was a little harder to find, but same thing. Everything kind of fits that. So for the Achilles tendon, plantar fascia, and patellar tendon, if they had an ultrasound at the beginning of the season that was abnormal, they're much more likely to get injured than if their tendon looked normal. And I was talking about how good these are as screening processes, as sensitivity, specificity, all these. I think the big one to look at is over here is negative predictive value. So that says if your tendon was normal, what's the likelihood of you getting injured? And if we look at ultrasound on the top, there was a greater than 99% chance for every single tendon that they're not going to get injured. So I think it's very useful if you say, I scanned your tendon, it looks normal. You're probably not going to get Achilles tendonitis over the year. The positive predictive value is if you look at it as abnormal, how likely are you to get injured? Fortunately for athletes, it's not very high. So if I scan their Achilles tendon and it's abnormal, there's only a 16% chance over the year they're going to get injured. But that's not as good as a 99% chance you're not going to get injured. So the positive predictive values are pretty low. The negative predictive values are pretty high for this. So what do we do with that? We're like, great, you have a high likelihood of getting injured. Good luck. So the next step is obvious. What do we do? We're going to intervene. So there's actually been this study was done back in 2008, almost 20 years ago. This is a really impressive study. And this was done in Denmark, where they took 12 pro soccer teams, tons and tons of athletes, and they randomized into two groups. They said, half of you are going to keep doing what you're doing, just ignore us. But half of you, we're going to actually intervene if we see abnormalities. And what they wanted to do was a stretching program, eccentric training for those tendons. So for the Achilles tendon, what they found was that if people had an abnormal ultrasound and they either did the control where they do what they always do, or they do the intervention, they're basically the same. So people were still fairly likely to get injured. So for us, it was 1 out of 16, or sorry, 1 out of 6. This is like 1 out of 3 are getting injured. But interestingly, if they did the patellar tendon, they were more likely to get injured if they did the intervention than if they didn't. And so you're like, well, that doesn't make much sense. But I think it does. I bet the physical therapists in the room are like, yeah, it makes perfect sense because you're just taking people who are playing all year round and then you're adding even more load to them and just overloading their Achilles tendons. Eccentrics are a one size fits all routine that they had for these people. So it was a great idea, but it definitely did not work. So for us, our thought is, well, what do we do about this? I think it's not going to be so simple as one size fits all. Within research, it's always protocolized. You have to do the same thing every time. Everybody has to do it exactly the same. And the theory there is that if you come up with this protocol, then you can use the protocol anywhere else. And so science kind of depends on that. You have to have these methods that you can recreate. But I don't think that actually works as much in the real world. Um, if somebody has a bad tendon, maybe there's a reason they have a bad tendon. So our thought is maybe they've got a functional deficit of some kind. Maybe they have a strength deficit. Maybe they have a balance deficit. Maybe it's a neuromuscular control problem. Why is their tendon overloaded? What is causing that? So for us, we actually look at it less as the intervention, but maybe figure out what they're doing that is stressing their tendon so much. As an example, we see a lot of our basketball players have unilateral patellar tendon issues. That is something that I find is much more treatable than the bilateral patellar tendon issues because usually it's something that we can fix with rehab. So for me, the intervention here is actually going to be rehab, but it's not going to be based on the tendon. It's based on what they are doing wrong. So we look at it more as a functional issue rather than a histologic issue. The histologic issue is more the canary in the coal mine, so to speak. So that is what have been working on a lot recently. And so we're applying for several grants for this sort of thing. Love to have other people involved as well. And this comes up a lot. I don't really even have a slide for this, but a lot of people will say, well, let's say you scan a tendon. What do you tell the athlete? So, especially when it comes to the pro stuff, we've done several studies on pro teams, and it is a sticky situation. So, let's say you're doing a rotator cuff tendon on a baseball player, and they have a partial thickness tear. Do you shut them down? Are they symptomatic? Or if you're talking about a pro runner and they have a small abnormality at the insertion of their Achilles, but they don't have any pain there, what do you do with that? For our studies, we actually grappled with this quite a bit. And when we first did our big study, we didn't know the answer. We were doing the study because we didn't know. So ultimately, what we did was we said, we don't know what this means, and we're here to figure that out. Um, and ultimately, we just didn't tell them what it means because we didn't know. I feel like we're at the point now where we know. So if you have an abnormality, you're more likely to get injured. But I think it's phrased more of you're likely to get injured, but it's still only a 1 in 10 chance or a 1 in 20 or a 1 in 5 chance, somewhere in that range. So it's still not very likely. But I think we're looking at it now as let's figure out why this is looking abnormal, see if there is a problem with your loading, see if there is a problem with your training program, see if there is a problem with your form that we can address. And I think that might help prevent the injuries rather than anything else. When it comes to money and agents and all this other stuff that we have to deal with, many of these, especially depending on the sport, many of the pro athletes don't want to do this because it affects their stock. If they say, hey, you are damaged goods, you're more likely to get injured. Why would they sign up for an ultrasound? May not happen as much in the running world, but the things will progress and it might end up there too. So these are just all considerations that we have to take into account each time we look at these. So for next steps for us, like I said, we're trying to expand these programs as much as we can. I think we have a pretty good protocol of how we're doing it. We've got a good methodology for that. We can expand it very easily. We're trying to make it now so that we can have less experienced people do these, but do them well. And the reviewing process is actually the hardest part. So that's what we're working on. And then ultimately, are we going to be able to intervene? So right now, that's still in the research phase, is what I would say. For anybody who is interested, please reach out. And that I think is going to be a good segue into Brian and Kyle and kind of how we met and how we talked things over, and it'll lead right into their ultramarathon study. So maybe I'll just stop there. We could save questions till the end and then let Brian, I'll let you take over at this point if that sounds good.
Sounds great. All right, I'll share slides here. Yeah, so I will have Kyle. Yeah, he's having fun somewhere in Italy. So I'm gonna play his part here, and hopefully you guys can hear it. Daniel, you give me a thumbs up if you when I start presenting, say you can hear it.
Yeah.
All right, here we go.
Hello, my name is Kyle Judkins. I'm one of the sports medicine faculty at Mayhec in Asheville at the Sports Medicine Fellowship, and I'm thrilled to be here. Thank you, Dan, for inviting Brian and I to talk with you. So we are building on Dan's story that he has already started telling you, and we are focusing in on some ultra athletes in the Western North Carolina region. So we affectionately call our study Ultra for Ultra or Ultra Squared. And so can we screen for injury in ultra runners using ultrasound? We wish we had disclosures. We're just not that cool yet. So why are we interested in ultra runners? They are very interesting athletes. They are mentally tough. They are doing things that are really pushing the limits of human capability. A good example of this is Courtney Dauwalter. In 2023, she won the UTMB Hard Rock 100 and Western States all within 2.5 months. These are all races that are at or slightly above 100 miles, and Western States is about 18,000 feet of climbing, but Hard Rock and UTMB are both 33,000 feet of elevation. And so, this is just a new frontier for running, and it interests both of us very much. Brian is a more accomplished runner in general. He is actually fast and also is doing 50Ks. I was a pole vaulter at a D3 school, and then just got into running for fun. But I love trail running. I've done 150K, and I've definitely got the bug to a certain extent as well. People are also doing more lengthy races now. 200 and 300-mile races are becoming much more common. The Hellbender 100-mile race is the local race in Western North Carolina. Brian and I are both co-medical directors and have been for the last 4 to 5 years. It has about 18,500 feet of elevation gain. The original course before Hurricane Helene, which we will be returning to next year, has 24,000 feet of elevation gain. And it's thought to be one of the more grueling 100-milers on the East Coast, and is also a Hard Rock and Western States qualifier. So we both love working with ultra runners. We are in this amazing part of the country for it, and so it felt like a nice transition and build for this study. Ultra running is defined by essentially being, I'd say it's loosely defined in general, but distance of greater than a marathon, essentially. Time, so this does not say that everyone running for 6 hours or more is running an ultra marathon, because it does take some people, that long to run a half marathon. But there are versions of races that are 6 hour, 12 hour, 24-hour races. So it's generally considered an ultra if it's 6 hours or longer. And then there's also multi-day or multi-stage events. It's also important to note that these are not all trail races. There are a lot of ultras that are pavement or trail or mixed surfaces, even tracks, especially if you have the backyard marathon picture. It could be really varied. So injuries in ultra runners, a slightly higher rate than recreational runners who run fewer miles. So there is definitely a relationship with number of miles run and injury. However, it is a U-shaped curve, as sprinters also have a significantly higher injury rate than regular, recreational joggers. Ultra endurance runners also experience about a 7.2 injuries per 1,000 hours of running, based on this one study that we found, and as you might expect, mostly in the knee and lower leg. Shear in 2021 did a review, and there were a couple of races that from which they gleaned data. There was one 1,005-kilometer multi-day road race, which sounds horrible to me, but main anatomical sites of injury were most commonly knee, and most commonly patellofemoral pain syndrome, and that was actually the most common injury overall, followed by ankle and lower leg. So lower leg would include plantar fasciosis, Achilles tendinosis, etc. 65-mile trail race was another component of this study, and this was on trail, so it was more elevation and on much more technical terrain. Acute onset of plantar fasciitis accounted for 28.6% of injuries, so this was not preceding plantar fasciitis, but acute onset. And then ankle sprain was also very common. Knee was also a common injury site. So what is the difference between trail runners and road marathoners? So when you're looking at trail ultra runners, they are generally running for a longer period of time and slower than road marathoners, even at the elite level. The training plans are often incorporating a lot more elevation gain, just to reflect the load that is required to finish one of these races. And then more acute traumatic injuries are much more common, especially ankle sprains and other injuries to the lower leg. Elite trail runners will have higher torque and power than their road running counterparts, but also will be more economic when running uphill. So much of the training is focused on how to move efficiently uphill. And you may have even seen power hiking as a major component to even some of the elite runners training and racing. It is all about how you move as efficiently as possible up this terrain. So there's a lot of practice, so they end up being better at it. This is a profile of the elevation for the Hellbender this past year. There's a little bit of symmetry, so you know there is some outback component to it, but it is a grueling race, and you can especially see at that 18-mile mark where it just shoots up forever, and then you have to do it again on the way down, which sometimes is harder. When we are talking about our study design, it is very similar to Cushman's and his several previous studies, but we have benefited from his experience, and we were able to not make some of the mistakes that he warned us about, and so we would definitely like to thank him for his support, collaborative spirit, and mentorship through this. But in general, a lot of our main study design was taken directly from his original design. When looking at our pre-race flow, we decided to not try to sign up participants beforehand. I think that there would be benefits to that, but in general, we felt pretty strongly that this was going to be sort of a sideshow, and people would be attracted to come and participate pretty willingly. And we were right. So pre-race email was sent out from us and the race director explaining the study, so everyone got that through. It was through Ultrasign-up. And then the day before the race, at the pre-race expo, our study team was set up at the main pavilion with very high visibility. And Starlink was on site. We actually had two Starlinks. We had a main one and then a backup one, just in case. And we had created a QR code that was linked to the consent and pre-race survey. And the survey was mostly injury history about patellar, Achilles tendons, and then plantar fascia, and then some running experience and training questions. We did throw in some other questions that were just interesting to us, so we took the opportunity to ask about shoes that were worn in training and in racing, shoe type, brand, etc. So we can sort of backtrack and figure out, are they zero drop? Are they 8mm drop? Are they foot shaped? Are they not? Are they high cushion? Are they super shoes, etc. So just sort of setting up for any future studies that we want to do. And we also asked questions about socks. So are you wearing toe socks or not during training and this race? And we ended up scanning 26 people between the hours of 3 and 8. There was a break from 5 to 6 for the pre-race meeting, and then from 6 to 7 there was dinner, but people were still milling about and able to come over and get scanned. So much of this was done between 3 and 5, and then 7 and 8. The equipment we used, we had two brand new demo Sonosite PX laptops, which are great systems. We did have two different types of linear probes, and I wish we had had the same type, and I would have done that differently if we were to do this again. We had two massage tables, one enormous tree stump that we could not move and had to work around, but ended up being helpful for us. And then two ultrasound gel bottles. When we went through, we brought 4. Probably could have brought more in case we had gotten more people to scan. Many paper towel rolls, and then probe cleaning wipes. Our scanning order, or our scanning flow, was also important. So we after the participant finished the survey on their phone, we made sure that our ultrasounds were set up to collect only video clips. We did this ahead of time, so we didn't have to touch it right before scanning, but just for information only. Collected only video clips, no stills, and we also set the video length to 10 seconds, which was important. It saved a lot of time for us as we were scanning. We decided to have their bib number be their patient ID on the ultrasound, and then also that became their main ID for the study. We did make preset labels. So instead of having a right and left label and then patellar tendon, Achilles tendon label, we just had right patellar tendon, right Achilles tendon, etc. And that saved time as well. We scanned the patellar tendons first, Achilles tendons next, and then plantar fascia. Both the second two patient were prone, and the patellar tendons patient was supine. We started with the right leg for each structure, and then moved to the left leg. Within each structure, we were scanning proximally to distally, long axis to short axis, anatomic right to anatomic left. And then we used Doppler to look at neovascularization only in areas where we saw abnormalities otherwise. So for example, we started everyone with right patellar tendon, long axis, proximal position, anatomic right, and then we proceeded from there. And then for the right patellar tendon, then we did the left patellar tendon, proximal, long axis, etc. So number of scanners was also an important topic that we discussed beforehand. Having one scanner really eliminates a lot of variability between scanners. However, it's also beneficial to have two scanners for efficiency, and we can also measure inter and intra rater variability. So we can look at the statistics here that may actually strengthen our study in the end. But ideally, to get a ton of people scanned, you would have a lot of scanners, but you have to strike that balance. So that concludes my part of this talk. Again, thank you for your patience with me and this video. Would love to hear from all of you. This is my email and my cell phone. Feel free to text me or email me with any questions. And now you get to hear from my fantastic colleague. Thank you. Enjoy the talk.
All right. I am aware that there's 1 minute left. So I got the fun part. I can breeze through most of this.
Brian,
So this
take
was
your
our
time. Take another 5 minutes or so, okay?
cool. This was our setup at Camp Greer, which is where the race starts. So we just had the two tables and the two ultrasounds, and we were kind of set up. So here's me scanning, and then I'm going to show you a picture. So like this is the perspective you can see on the bottom left of the screen of where we were. This was like the pre-race meeting, and there are people kind of milling around, registering for the race and stuff. So this was the day before. So it worked out pretty good to be right there, and people were intrigued about what the heck we were doing over here, and ended up getting us a lot of people that were coming through. Um, Here's the race start. Ultra marathons are awesome. Here's some fun pictures I'm going to breeze through. Some of our colleagues who are racing. You might recognize this guy, Sarah. Brian Gottwald rotated with her. He is one of our former fellows. Um, Here's us trying to figure out how ultrasound works. And then we actually, Kyle has a sick camper, so we camped out because, part of it, we did a pre and then we also did a post race scan. And so people were coming through, that people finished between 20 and 40 hours for this 100-mile trail race. And so a lot of people were finishing in the middle of the night. And so we camped out next to the finish line, and people were coming through. It started coming through around midnight, and then we're coming through in the early hours of the morning. So someone would come grab us, and we'd scan them when they finished. There's Kyle, sleek. Okay, so the post-race study flow. So we scanned as many as finished the race afterwards as well, as which I was talking about. So that was 18 of them. And then we sent out an immediate post-race survey, and this was all modeled after Dan's previous studies. And we're going to have surveys at a month, 3 months, 6 months, etc. So what we learned, so I think like part of the reason we're here is because we are among those, I think Dan said, less experienced people who are trying to perform this study. And so it was extremely helpful to have him guide us through it. And he gave us a lot of his time, which we're very grateful for. But we'll tell you the things that we learned if you out there are interested in doing your own version. The efficiency piece, so it still took us a little while, and I think it's kind of one of those things that you kind of get the hang of it as you're doing it. So halfway through, we were kind of getting our flow of how to do this more efficiently. Space is tight. You saw the corner. It was tight. And just some ergonomic pieces would have been helpful to have someone hit buttons for us. that might have sped things up and made our backs hurt less. Kyle touched on that we had two different probes, which was not really our choice, but we did get two free ultrasounds for a while, so I can't complain too much about that. Um, and then just some extra equipment that we wish we would have had. Yeah. So we just did that. That was like in May that we did this first part of the study. The first surveys have gone out. We've had a like really high response rate despite not having a grant yet and no incentive. And so we're going to review those videos, measure our reliability between Kyle and I on our reviews of the videos, and then we'll keep sending those surveys out and try to model things after how those previous studies have been done that y'all have heard about. And then we'd like to continue doing this. Kyle and I are both uh, co-race directors of this race and then several other ultra trail races, no other hundreds, but 100Ks and 50 milers. So that's something we feel like we could keep collecting data on. And that's it. All right, leave time for questions.
Well, this is fantastic. And I thank you again for coming to talk. I think a couple of things I get with this, number one, talking about tendinopathy and how frustrating it can be to treat. So if we can catch it early, I always talk about primary prevention. If we can treat things before they become a problem, so much better. Make happier patients, but how do we convince them to actually do the treatments, right? I think the other point I wanted to make or kind of reiterate is I think there's so much value in going back and repeating some of these studies, right? I mean, you learn so much from each one. And also, are you getting the same results? Are there things we can do better? Can we look at different body parts? And so I think especially some of our earlier faculty who are on here and getting their toes wet with some research, I think these are great tips. And so I appreciate you going through all the details and some of the things that went well and some of the struggles, because that's the joy of research, right? So if anyone has questions, I've got a couple that have come my way. So I'm going to go ahead and throw these out there. My first one is very broad. And so, Dan, I think this is geared kind of towards you, but what are your thoughts in terms of extrapolating this, right? So we're talking primarily about runners. And then we're also talking about, two tendons or three tendons, fascia. What are your thoughts in terms of being able to extrapolate that to other populations, to other tendons? Do you think there's sticking points? Thoughts on that? Very
Yeah.
general.
Yeah, I would say probably many points.
Yeah.
First would be probably the person in front of you, the runner. And I don't think I have ever had a runner come to me and be like, "Can you help me prevent injuries?" Like it's always like something hurts, and so therefore I want it dealt with. But that's also just human nature. I don't know if I've met many people at all that would do that. And so I think somehow getting to the point where we can convince people that would be great. That would be awesome. I do think that at the higher levels, there's always that push because especially even if they had, I don't know, a proximal hamstring injury 3 years ago, they are like, I never want to be injured again. So they're actually more motivated to do something at that point. In my opinion, when it gets to then like what about the runner, I think age plays a huge role. I think old people like me, I think a lot of our tendons are going to look abnormal, and I think they are actually less likely to get injured than a younger person with the abnormal tendon. I just think that the wear and tear over time, that changes, the adaptations. I do think there's a difference between a thickened tendon that is normal and a thickened tendon that is abnormal. I think there's different appearances for these and everything. So I think that when it comes to age, I think that it becomes a little bit trickier. But I think it's actually still probably the same philosophy. I think it's just going to be more nuanced. And I think when we look at 700 younger athletes and we look at 700 older runners, I think if we did 700 older runners, I think we'd actually be able to say, yeah, those are the ones that we would worry about, and these we wouldn't. So I think it's actually the same principle. I really do believe that. And then for other tendons in the body, we looked at big tendons. And I think these kind of big weight-bearing tendons that you use for every step are going to be different than the little tendons. So the peroneal tendons, we see those post-tib tendon, FHL, those kind of things that we still see in runners fairly commonly. I think those are going to be much harder to identify precursors than the big ones. I think the big ones have far more reserve, if that's a word for tendons. And I think that the little ones tend to be a lot more of kind of the inflammatory type picture a lot of the time. Now, saying that, I think we've all seen runners who have, massively swollen peroneal tendons, and that's what's causing their pain. And we've seen the ones with the split thickness tears and all these other things. We don't see the Achilles tendons who come in with a split thickness tear. They all have tendinopathy. And so I think that these subtleties between different tendons and everything that you figure out as you do more and more of this clinical medicine, I think that those are going to be much lower yield. And I've had these discussions with other researchers where we're like, well, maybe we can set up this thing where we scan every tendon and we look at every single tendon in their body, kind of the whole body MRI thought, right? You just scan everything. Um, I think it's a waste of time. I think that like not only is the prevalence a lot lower for other tendons, but I think that you don't know what you're dealing with. And especially, I mean, we've definitely all seen post-tib tendonitis where their tendons look pristine, but they got tons of symptoms and it's really a tendonitis. But that again is much less likely to happen with these other ones. So long answer for that question.
No, I think that's a good point. And yeah, I was having a conversation with a dietitian this morning. And we're talking about how do we get through to adolescent athletes, right? Because I did a QI project and the folks who had injuries, they were much more engaged than the folks who had not had an injury, right? And
Hmm.
so I almost wonder, runners love data, right? And so if we can show them a picture that, hey, there's this little thing that's wrong, maybe we want to address it. I think in the context of my practice, if you're seeing instability in lower quarter and you can identify there's a tendon that may be an issue, and if I could show them, hey, this is here, there are some studies showing that this can increase your risk of injury. So I wonder kind of incorporating all that and weaving it into the data mine, if that can help us in terms of convincing from the primary injury prevention. But yeah, let me know when you figure out how to do that for runners because I'm working on it.
Well, I would say runners are even harder than adolescents. So,
Yes.
God forbid they're
Yeah.
adolescent runners.
oh
Yes.
God.
Yep, that's the population I like to
Oh.
address. So a couple other broad questions. Do you have an opinion on elastography and the potential for predictive values?
I definitely have opinions on this. So one of our former fellows, Sarah Eby, she did a PhD in elastography and then did a sports medicine resident or did PM&R residency, sports medicine fellowship. So she knew what she was talking about. And she really swayed my opinion on it because it's such a good idea, but it doesn't seem like it works. The problem is it's just really hard to get information that you can repeat every day, that's always the same. And then the problem that we also see is it kind of shows elastography shows stiffness of tissue, and that seems to change over time. Um, and I'm just not convinced it's any better than what we would see on a regular ultrasound machine, actually. I don't think you get you, I guess I would look at it this way is ideally you would say that tendon looks abnormal, so I'm going to put elastography on it. If the tendon looked normal and you put elastography on it, it's not going to tell you anything. So you say you're already starting with an abnormal tendon, which is kind of where things currently are. I don't know if that's going to show you anything extra than being like it doesn't look normal. That's my view. I think other people will disagree with me, but so far I have not seen a single study that has proven us wrong yet.
Sure. I've got one more question from the audience. Can you share more details about which outcome metrics from B mode ultrasound you use to identify abnormal tendons?
Yeah, and so for us, we use three main ones, and that is um, hypoechogenicity. That means kind of a black area within the tendon, but it has to be kind of a focal area. The second would be vascularity within the tendon. Tendons shouldn't really have blood vessels within them. And then the third is thickening. And this one to me is actually the one that I would probably get rid of, as crazy as it sounds. And that's the one that most people focus on. The analogy I use a lot is if I take a ballerina who is 5 foot and weighs 80 pounds and look at her Achilles tendon, and her Achilles tendon is relatively thickened, versus I take an NFL lineman who's 350 pounds and has no symptoms, his tendon is going to be thicker than hers. And so there's this overlap between normal thickening and abnormal thickening. And I would say the abnormal thickening always has hypoechogenicity in it. So for me, I actually look at that hypoechogenicity as being the key piece of the thickening. So we no longer take measurements because we're like, what does that even mean to us? So it's actually more the morphology of the tendon rather than the size, if that makes sense.
Excellent. All right. Well, we're at 7:57. I really appreciate all of you coming to speak and sharing your research and where we're going next with all this. So thank you. Um, for the folks who are here, we are going to be having our next session in July, so July 8th. Dr. Stacy Schley from Boston Children's is going to be talking on some topics from relative energy deficiency in sports. So look for some announcements on that. Reach out to me if you have any questions, and share these links far and wide and bring folks in. These should get posted up to our YouTube channel eventually, not necessarily timely. So thank you all, and have a good night, everyone.
Thank you.
Thanks, everybody.